talked a little bit about the distinction between MDS and AML. How do you stage MDS?
Right, so I think we talked about the WHO classification. That's really more pathological, and sometimes you could just say a simple way, I'm gonna take patients that have excess blasts or no excess blasts and use the WHO classification. But the WHO classification doesn't capture the whole disease, and the risk stratification or staging in MDS is really based on three variables. One are the blood counts, so obviously cytopenia, the blast percentage on the bone marrow, and the cytogenetics. And nowadays, we started integrating some of the molecular data from somatic mutations as well. So the standard had been the IPSS, or the International Prognostic Scoring System, that usually gives a lump score based on those variables. And based on that, we classify patients into 4 stages. As hematologists, we always like to call them low, intermediate, intermediate 2. I never knew why not called stage 1 to 4, but that's how we name them. And basically, the survival varies from somebody that have less than 1 year survival to somebody that have more than 5 year survival. We all knew that the IPSS had some shortcomings, like it doesn't account for the depth of cytopenia. So if somebody's platelets were 10 or 90, they got the same scoring. The cytogenetics were kind of simple groups of lumping the patients into cytogenetics. So the IPSS-R, or the revised IPSS, tried to address some of those shortcomings, accounting for the depth of cytopenia, more for the blast percentage, but also very detailed cytogenetic information. And now we can put the patients into 5 categories. And again, the survival will vary from less than a year to somebody that has very low risk, almost 8.8 years survival. So I look at the risk stratification in a way that it's gauging the risk of the disease. It's important information for the patients, obviously, but we also tailor the therapy based on the risk. And in reality, we are just thinking, are we going to be able, or can we justify taking those patients to allogeneic stem cell transplant? Is there enough disease risk that will allow us to take those, or justify taking those patients to transplant? Because the transplant, unfortunately, still have mortality and morbidity associated with it, although it's the only curative option. Now, in the next step, we started integrating some of the molecular data. So we know that there are certain mutations that add to the clinical variables. And there are several papers that look at several gene mutations. I think some of the established ones, for example, P53 is always a bad mutation. SF3B1 is really the only good mutation when it's present by itself. Everything else could be somewhere in between. But things like ETV6, EZH2, SXL1 tend to have bad prognosis. So I think nowadays we do the clinical models, we complement that by some of the molecular data, and we come with a risk assessment for the patients. I also try to look at the disease tempo. So I look how stable are the counts. Somebody who's progressively becoming cytopenic, symptomatic, may behave differently from somebody that, although is coming intermediate risk, but had stable disease for a long time. So the disease tempo could be an important part of it as well. So, and then based on that, obviously, we tailor the treatment according to that risk stratification. There are different models used, more sophisticated. I would say maybe the IPSS-R is the most used model. It's important to keep in mind that the disease really affects even what we call lower risk. Like we looked at this in the MDS consortium together, and even patients that we called lower risk, when we look at that, 25% of those patients unfortunately died within a couple of years. So even what we call a very lower risk is a disease that's going to probably impact the patient's survival and quality of life.
I think you bring up a really good point in the idea of a tempo, which is not captured actually by any of the risk stratifications. So you can see a low-risk patient, but their progressive cytopenias over a 2-month period of time are really impressive. And you know that patient is going to do worse than a patient who has a relatively stable tempo. And we don't have a really good way to sort of prognose for that when we first see the patient. And many times, patients in a risk category surprise us. They don't behave by the rules. And I think the tempo is one of those ways that we're able to determine who those patients are.
Yeah, unfortunately, there's some shortcomings to both the IPSS that may have been addressed by the IPSS revised, but still for both of them, I think you cannot utilize that for therapy-related disease. And I see this get done all the time, and yet those patients were excluded from the analysis. And I also think that it's a problem because it's not dynamic, and nor can you use it in people who have been treated previously. So you're left on your own if someone, let's say, failed the therapy and then how do you go about their classing? Although I do think that the French group had an idea actually for perhaps risk stratifying patients after HMA failures. And it's, I think, an interesting way of thinking about it, but I don't know that it's been utilized that
But
much.
stratification after HMA failure is always a pretty dismal stratification. I mean, those patients that fail HMAs, we really are at a loss for, you know, how we're going to really treat those patients and extend their overall survival.
So if I'm a general practitioner and I'm seeing every week patients with a bunch of different diagnoses, I'm seeing some with breast cancer, lung cancer, colon cancer, chronic leukemias, and by the way, an MDS patient, you know, here and there. Is there an easier way to think about risk stratification? Because personally, I'm almost embarrassed to admit this since I do this for a living. I have the revised IPSS up on the wall of my workroom with all the different cytogenetic risk categories because I can't memorize all of that. So I've got to go and check it and calculate a score, or go on to an online app like the MDS Foundation has where you can actually put in information about this. What's a quick and dirty way to think about risk stratification for patients with MDS?
I mean, I think the IPSS and the IPSS-R is a good place to start. There's no doubt.
But if you can't memorize that, let's say
Yes.
you're in a busy clinic, you can't remember that, you're seeing somebody with MDS, quick and dirty, how do you risk stratify?
I have it on my the clinic, one of the clinic walls. Or there's an app actually.
I think you look at the components, like if the blasts are increased, cytopenias, the chromosomes look bad, more than one line. I don't think you need to calculate a score, basically. So really looking at the components. Maybe nowadays just thinking of complement that by asking for molecular testing. But it's really, I think I've heard you talk about this before, like in simple way, blast more than 10%, it's not gonna be good, right? So that could be a simple starting way. Depth of cytopenias, blast percentage, and cytogenetics, if they are complex, you don't even have to calculate a score.
So if you have a patient who has high blast percentage, more than 10%, right, we all agree on that, multiple cytopenias, and somebody who has poor risk cytogenetics, and the easy ones to remember are chromosome 7 abnormalities, those are always bad. And if a patient comes in with a paragraph of cytogenetic abnormalities,
Complex carrier.
It's very
you know
bad.
they're going to have very poor prognosis. That person is high risk and should be treated as such.